very difficult question. Counseling of these patients, it's very difficult. As recommended by current guidelines, risk-reducing salpingo-oophorectomy should be considered when the patient has completed their family planning. The current guidelines also recommend risk-reducing salpingo-oophorectomy at the age of 35-40 for BRCA1 and 40 to 45 for BRCA2 carriers. I mean, because we are postponing the first pregnancy, patients at 35 years may have not completed their family planning. So we need to counsel them knowing what the current guidelines suggest and what these results, our results and other literature results suggest on this counseling, but the patient comes first. So if the patient has a childbearing, if the patient has a strong willingness to complete their family planning, they can consider postponing risk-reducing salpingo-oophorectomy. And another fact that should be taken into account is that the risk of ovarian cancer in this population is also dependent in a certain way on the family history. So if the patient has a first-degree relative with a history of ovarian cancer at a very young age, it's quite different counseling these kind of patients compared to patients that may have no history of ovarian cancer, just history of breast cancer in the family or ovarian cancer at older age. So the counseling should be individualized and based on patient preferences and what we know, and it is shared decision in the end. The point is that it's very difficult to conduct a randomized controlled trial in this setting. We cannot randomize patients to salpingo-oophorectomy, yes or no. It's impossible and unethical. So one of the highest level of evidence in this field to try to answer this question come from observational studies. So we acknowledge that our is a retrospective observational study, but it's still one of the highest level of evidence we can give to help the counseling and help the counseling, let's say. And another important thing that it might be worth discussing is that all patients should receive BRCA testing at the time of diagnosis or even before the time of diagnosis in case of family history, because the timing of BRCA, we demonstrated in another paper that the timing of BRCA testing, it's associated with survival outcomes. So we have to have the result of the test by the time we have to make the counseling and these decisions with the patient. Is very important. Unfortunately, in our database, we did not collect information on quality of life or psychosocial effects of these surgeries, but we have planned for the future, because there are still several areas where we need to improve the evidence, the available evidence, and especially on how to counsel patients with pathogenic variant, not BRCA. I mean, we know that there are several other genes that increase the risk of developing breast cancer, but we know very little on the management of patients with breast cancer with beyond BRCA pathogenic variants.